Hello and welcome to a brand new edition of the Mumbai Manifesto. Hello and welcome to the 9th edition of the Mumbai Manifesto. Now Mumbai has a lot of things to be proud of in its public services delivery, and one of those pillars is public healthcare, municipal healthcare. And to discuss this critical topic, we have with us today Dr. Avinash Supe. Now Dr. Supe is a leading gastroenterologist of Mumbai. He has an amazing career of working in the public sector of healthcare in Mumbai. He's been the former dean of two of the largest municipal hospitals in Mumbai, both at the King Edward Memorial K.E.M Hospital and at the Sion Hospital as well. Besides this, he has been at an administrative level at the MCGM as the Director of ME&MH, which is Medical Education and Major Hospitals. Dr. Supe loves teaching. He is a researcher, he is a scholar, and he has over 600 articles which are published in peer-reviewed journals. He is loved by the entire medical fraternity in these public hospitals. Wherever he goes, he has a large fan following and has received several awards. One of the most prestigious ones he's received is the Dr. B.C. Roy Award. Now, Dr. Supe comes to us today as a doctor, he comes to us as a researcher, he comes to us as an administrator, from the very pinnacle of public and private healthcare in Mumbai. And like all other guests who come on the Mumbai Manifesto, today Dr. Supe comes to us first as a Mumbaikar. Welcome to the Mumbai Manifesto, Dr. Avinash Supe.
Sure. Thank you, Gautam, for really inviting me here. It's such a pleasure to meet you.
Welcome. Let's begin. As it is with everything to do with public infrastructure in Mumbai, it comes down to the population and the population density. Dr. Supe, we've had some of the best hospitals in the country, giants of institutions, but they're old now, decades old, some of them more than centuries old maybe. How do these institutions cope up with clearly what is an ever-increasing load of patients that come from across Mumbai?
I think these institutions started somewhere 100 years ago. K.E.M is going to finish his 100 years next year, and Nair Hospital already finished his 100 years about few years ago. And Sion is around more than 70 years old, and Cooper is only about 20, 30 years old. However, that if you really see, these institutions were built at that time. K.E.M was built in 1925. It was in the outskirts of the city. And over a period of time, the city has grown and the suburbs have grown. So if you see today, if you see the Mumbai population, which is somewhere around 1.4 to 1.5 crores, 25% of the population stays in city of Mumbai, while 75% of the population stays in the suburbs. Now, this is where the problem really starts. The most of the major hospitals, like tertiary hospitals, and most of the hospitals, like the hospitals for special diseases, and 50% of the dispensaries, 40 to 50%, are in the city, and the population is in the suburbs. So that's the problem. So many of the people, and again, you know, population is divided into more into, say, about 50 to 60 lakhs almost into western suburbs, and 40 lakhs into eastern suburbs, while these 31 lakhs only in the city. That is what is the current population around. Now, if within that structure you will find what has come out is the peripheral hospitals, which are secondary hospitals. So the primary, tertiary care hospitals are mainly in the city. Super specialties are mainly in the city, while the secondary hospitals, which are in the suburbs, and peripheral hospitals, if you really see, peripheral primary care hospitals, you see, there is a difference in the need. Means basically what mostly corporation feels is that every 50,000 population, you should have one dispensary. That is what we say. So we should have more dispensaries currently.
By dispensary, you're saying primary healthcare
Primary healthcare centers. But as per the some of the parameters like PHFI and all, you need 15,000 per population, you need one dispensary. That means we are quite short of dispensaries as per if you see some of the reports. And if you consider 50,000 per one primary dispensary, usually there is a shortage of those dispensaries. That is one. Now what has happened, your question was very relevant. The hospitals were built at that time, though these are very large hospitals, like say K.E.M Hospital and Sion Hospital. They are now, K.E.M has around now 2,000 plus beds, and Sion Hospital also has around 1,500 beds. It is just the kind of load we get, it is difficult to really cope up with these loads. I mean, to give you footfalls, I mean, if you can give us some footfalls, if you really think, K.E.M has about 20 lakh plus OPD patients every year. That means 2 million patients, about 8,000 plus patients come every day. Similarly, in a Sion Hospital also you get 7,000 to 8,000 patients per day, but the Sion capacity is less. If you look at the emergency workload, I mean, if you find the kind of patients we get, about 700 to 800 patients we get per day in emergency setup and casualty. And maybe out of that, about 100 to 150 need an ICU and about 50 need a ventilator. And same thing is in Sion, you get about 650 patients per day, and we also had the similar kind of thing. Now, any kind of an expansion, you will realize currently, we are not able to really cope up to this kind of an expansion. So, there has been a lot of effort to decentralize and improve the peripheral hospitals and try to see that how we can really develop. I'm sure we continue to talk on this, but the kind of the old hospitals, second problem of all these hospitals is today we are facing is the expansion and the shortage of staff. Coping to this. I mean, I'm sure we have one of the best super specialty hospitals. We have the best brains who stay there and who continue to operate, and development does occur in many departments. But as I said, when the numbers come, they become less. And the buildings are old now, especially K.E.M Hospital is a heritage building, type 2 heritage building. Trying to make some change or build a new building becomes extremely difficult. I mean, even to repair, I need permission of the heritage committee, and we have to go through those special contractors, and it's a very long process, but we have been doing it. The new buildings to build, we don't get permission so easily to build, and that's the problem in these hospitals. Plus, the work is so much that you cannot completely stop the work and do this repairs.
Right. When you say that, there is a resource crunch, are you talking about the doctors, or are you talking about the sort of support staff, or you're talking about both?
See, actually, if you really see corporation, I must really say that corporation is one of the really spends a good amount of money onto the health. If you really see across India, we spend almost about 15% of our budget on health.
Wow.
And which is a 12 to 15% if you really see. Now, last budget was somewhere around 7,000 crores, which is a huge amount of budget for any civic body to spend on the health. I must really tell you, BMC, we have been doing it. I mean, once upon a time, somewhere in 70s and 60s, it was 25%. But today, it is still 15%, and it is still sizable on stuff. So, I don't think corporation has money crunch as such. I mean, we are much better off than many other hospitals in the world, I mean, in the country. The problem is the staff. If you really see, the staff positions are not being able to fill because of various reasons, maybe because of the reservations, COVID, lose of staff. If you see, more than 30% of the positions in lecturers and nurses are vacant. And these need to be filled because of they are stuck with the various issues. Because
what is the reason for the vacancy?
Many people leave, retire, and then they are not filled because of the reservations. The proper candidates are not available in that particular way. Secondly, you will find as you said, there's a lot of issues which are going with these reservations, so we are not able to do that.
Correct. Some of those positions themselves as
positions
reserves.
block are not
Understood.
able to do.
Understood.
Then processes, elections, you are not able to really advertise them. And
Right.
then people who come don't stay. During COVID time, there was a lot of surge of people. Many people left.
It's
And
very
there's a
interesting, you know, some of the issues, because now this is, like I said, the 9th edition of our manifesto, and we've discussed a lot of public delivery of services. Red tape seems to be, you know, an issue in some places which is consistent. It varies. I mean, it is expected also across institutions. But similarly, you know, administrative reform can also bring about certain change. But what I'm hearing from you, Dr. Supe, is the MCGM ought to be sort of thinking in the direction of mirroring a K.E.M and Sion setup for the eastern suburbs and the western suburbs at least, perhaps larger than what they have in the city footprint, because you mentioned the populations exceed city for eastern suburbs and western suburbs in Mumbai. A very interesting question though as a follow-up is it just Mumbai, or do these hospitals get a significant footfall from outside Mumbai, outside Maharashtra?
Actually, if you really see, when we say Mumbai, we talk about 7 municipal corporations. I mean, it is from the Vasai Virar, Mira Bhainder, Ullasnagar, Kalyan Dombivli, Vashi, and Badlapur and all. These all are mainly catered for complicated patients by Mumbai hospitals. So that I think we have to really understand this. And so outside patients, around 30% they come. In super speciality, it is higher numbers. But if you see,
This is outside MMR.
out of MMR, overall, if you find outside Mumbai, actually, outside Mumbai patients are around 30%, and for super speciality, it is much more.
Okay.
So that is the kind of a statistics we see. So definitely we cater to the whole. To those previously, I remember when I was a student, we used to get even patients for doing hydrocele coming from Uttar Pradesh. But now I think we don't get that. We get it for now super speciality and complicated. Your first question was a very interesting question. When I was, as you said, when I was a director about say 6 years ago, 5 years ago, we thought about this, and that time we developed a plan which we created kind of an group of hospitals in various parts of the suburbs. That means there will be group of hospitals in western suburbs, something like say Bhagwati Hospital, BDBA, and few hospitals there in Malad. So that would cater to the north portion of the Mumbai. Then Cooper and Jogeshwari Trauma and Gorega Hospital would be one kind of a thing. Then MT Agrawal and Vikroli will be one kind of a thing. And Kurla, Shatabdi would be one. So
Correct.
we strategically planned big hospitals in this area. So we have now anyway, that time I had planned redevelopment of Bhagwati, then MT Agrawal, Shatabdi hospitals, which are now ready after 5 years, and those huge buildings are ready.
Right.
Now they are waiting for the installation of these hospitals. So the whole plan was that time that what do we really lack in these peripheral hospitals or suburban hospitals? There was a staff members. The expertise was limited there because there were no super specialists and specialists which were there. That was the first thing. And second thing was their infrastructure was not there. So now I think infrastructure is ready. Another good thing what during my time was we had done was we started DNB courses in these suburban hospitals. I mean these peripheral hospitals. Now that after 5 or 6 years has started showing results. Now many of the centers have DNB seats.
Just for our listeners, what is DNB, sir?
DNB is Diplomat of National Board.
Sir.
So these are postgraduate courses in various departments like surgery, medicine, then anesthesia, gynec. And so these definitely bring the consistency, improve the quality of the emergency and the regular treatment which is given. So peripheral hospitals output improves. Otherwise what happens, you have a complicated case, they just pack it to the K.E.M and Nair. Now that percentage of transfer rate has gone down.
Right.
Of course, the load everywhere is more because of the population is rising, but we do not want patients coming from our all these secondary setups to primary setups for simple things.
Right.
You know, I mean, it is sometimes very Um, Interesting, I think when we had done one study where we studied K.E.M skin OPD.
Right.
Okay.
Right.
And we had 800 patients coming to skin OPD that time.
Right.
And we analyzed from where they are coming. And every day out of 800 patients, we found 350 to 400 patients were coming for simple causes which could be treated easily in Malad or Maloney or Borivali. It was only one of the component was trust, another component was non-availability. So how do we really take away this and make these hospitals more efficient so
Right.
that, and they have capability. It's not
Right.
that they don't have capability. So it's a
Right.
question of trust building and developing the resources and centers so that there's a decentralization of the health system in
Understood.
Mumbai,
Understood.
which would definitely be of a great help. So I
See.
think then we can have a structure. Primary health care will treat mainly primary diseases and public health work. Secondary hospitals treat the main specialities, and hospitals like K.E.M, Sion, Nair should do super speciality and complex work.
Right. So it's very interesting how you explained this very beautifully. Our follow-up question actually has to do with exactly this. That what I'm getting from you is that there is a need for filtration as per the primary, what gets done at primary and how it escalates to secondary, how it escalates to tertiary. If that is a little more organized, then the footfall can be managed much better between these three
Sure.
resource bases. Now,
See, recently I was in Balasore, actually, in Orissa, and I saw working with LG Prasad Institute, Eye Institute. They had a wonderful structure, I must tell you. They have one center in Hyderabad, which is the most tertiary, super tertiary center. They have 3 tertiary centers in the Vijayawada, Vizag and Bhubaneswar. Then they have 28 secondary centers and 300 vision centers. So
wow.
it's a wonderful structure. That
Correct.
means vision centered, somebody would check only vision, give spectacles, they would check the glaucoma and all. Surgeries will be done at these 26 secondary centers. Complex surgeries will be shifted to the tertiary centers, and research and education is done at these 2 centers. So I think we need to build up this, but unfortunately what happens in a private setup where they have a control, they can do it. In a public setup, when we have so much of political pull, I think we, in working in corporation, it's easy to think, and develop this structure. But when you start implementing, every day you will find the politicians and local people coming and demanding that we want this at this place, we want this at this place. I think that makes it very extremely difficult to run,
Correct, correct. These are, it is very interesting because this is a theme that is emerging across different disciplines. Beyond healthcare, just running a city, this is a recurring theme. Red tape, administrative hurdles, sometimes political will. It's coming back to the primary healthcare centers, and this will get lost in this topic. Coming back to the primary healthcare centers, how do they fare? Now we've understood the load of the numbers you have mentioned, the range between 15 and 50,000, 50,000 being recommended. We still get the feeling that they're being underutilized at some level. That you mentioned the word trust. That maybe there's a greater trust that a citizen of Mumbai will put in a K.E.M hospital, but if you tell that citizen, you're not feeling well, first go to your primary healthcare center, the reluctance will be a little more.
Trust, I tell you, is basically trust also. And the attitude also matters a lot in these places. Basically, corporation has a huge budget, but only 2 to 3% or 4% is spent on primary healthcare. Forget about special hospitals. If you really see these special hospitals is different, For example, like say you say ophthalmology hospital, leprosy hospital, TB hospital, and these are different hospitals. Okay, forget about those 5 hospitals like Kasturba and all
Right.
those are different.
Right.
But if you take the maternity homes and primary healthcare centers, like you have say about 200 plus dispensaries and about 200 we have these primary first aid centers or something like that. The budget is very low first. Secondly, the kind of staff we have there are usually MBBS doctors, and they need to be upgraded and trained all the time. So their motivation and their work culture is an issue. Most of them work from 9 to 3, 9 to 4, and they don't have evening when actually people have the time.
Right.
See, basic
Is it a salary problem?
Not a salary. They want that kind of a job. Salary is also low, but the whole problem here is the model. It's also is an issue.
Right.
See, currently, if you really look at for when you're working in a Sion, I had very close contact with Dharavi,
right,
and Top Hill and Kurla. There are 3 big slums around Sion. Now you talk to those people, and then we started working in those areas. You know, something very interesting to really work in those areas. So we worked on malnourishment, we work on their timings, OPDs and all. Now if you see Dharavi, the most of the people will be working from morning to evening. And now if they have to come to a place like Sion, they would spend their whole day, and what would they eat? They would lose their daily wages. So instead of that, many of them would work from morning to evening, and then evening they would go and take 150 rupees injection from their general practitioner, and they would go. Now here, the health system of corporation probably doesn't come to help.
Correct.
Now that is a problem. So these are the people who can, I mean, there were a lot of attempts by our commissioners to make this evening kind of an OPDs. Some of them have been successful, some of them have not been successful. But if you cater to the people, or something like Mohalla Clinic was a good system, if you try to bring such kind of innovations, then there might be primary healthcare reach may be much better. Primary healthcare people are committed, they do lot of national programs, they do lot of maternity programs, they do lot of epidemic control and all, they do lot of work. I'm not saying we have been doing a lot of, if you really see last few years numbers, except for hepatitis B and C, most of the number of cases of diseases have come down.
Correct.
Whether it's tuberculosis, dengue, whether it's lepto. So that has been a good work, but the trust factor is less in this, and that's the reason you find most of the people will go to the private practitioner and do out-of-pocket expenses.
Even the poorer people.
Yes. So poorer people go outside and they do it, and they are reluctant to come to major hospitals for OPD unless they have something which is huge. But nowadays I think some of them come because of these government schemes, like surgeries and all being done, because most of the government schemes are done in these hospitals. So Mahatma Phule and Pradhan Mantri schemes are done, so many of them will come.
Right.
But that percentage is less. Most of them for a routine OPD would not like to come to.
It's very interesting, because the way we understand it is the best doctors in the city are residing in these municipal hospitals.
Yes, but the time given by them is a problem. Like you have a 250 OPD, and I mean, you will be seen, people have feeling that will be seen by a resident, and then the senior doctor may not give me time, and I'll have to wait for whole day to see him for 5 minutes. Now, this is where the issues come.
I think this is bound to be a little bit of give and take, a tug of war, because there's a time crunch, there's a resource crunch, and the number of people wanting to be seen by doctor is large. Coming back to the primary healthcare centers, you know, and you mentioned slums. I think it's a very interesting topic, that the profile of people that you would see at a Sion would be more slum compared to maybe a K.E.M, simply because of what it is surrounded by.
So many.
And we must acknowledge here that slum residents are the marginalized majority of Mumbai. More people live in slums than do not.
Yes.
Now, given this situation and your experience, what are the other risks different for slum residents that you see? If so,
most of the slum residents who come are, I mean, see, there are, if you really see, many of them are nice people. It's not that something they are bad, but some of them are sometimes illiterate and make noise, and that is bound to be there. So if you see the kind of, nowadays we see the kind of patients we see in all these hospitals. I won't say only slum people make noise, there are others also make noise. I don't want to really blame slums for this. But in public hospitals you find the kind of demands and supply which happens, because many times patients have to wait for a very long, and then there is a lot of irritation, they make noise and all that does happen.
Yes.
So the chaos, there is definitely some degree of a chaos in the emergencies do happen.
Chaos is bound to happen when there's so much gardi.
Rush.
But in terms of their vulnerabilities, are they more vulnerable than the people who live in the formal city to disease? Are they more vulnerable? One would imagine because of the level of hygiene, of level of basic urban services that are provided to them, water supply, sanitation, sewage, solid waste management, being subpar. Are the health implications clearly making them more vulnerable, or this is not the case in Mumbai? Is there something that links like this?
See, I personally feel slums definitely have some issues, like say malnourishment is there. It's not because they don't have money many times in Dharavi. It's the type of food, wrong food they eat. That was the finding which we had when we studied about 800 children in Dharavi. We realized that many of the mother and father would give money to the child, and instead of eating any healthy food, he would eat chow-mein and all other things, and that's the reason he becomes malnourished. But malnourishment, more kind of an TB in these areas is slum areas, because there is no ventilation, air is poor, gastrointestinal diseases, dengue, and these are definitely more common in slum areas.
Right. Now, we'd like to focus more on this word trust, and we'll just sort of analyze it a little more from different perspectives. From being at the zenith of healthcare in India, municipal public healthcare in Mumbai has of course been overloaded, but its image has taken a bashing, something we have alluded to 2-3 times. To the point that despite having, like we've discussed, the best doctors, the most qualified doctors, academically the best doctors, having the most experienced mentors, having the best equipment, having a very big budget annually, even then the poorer sections also of society are gravitating to private healthcare on a regular basis. Sometimes people who can't even afford it are forcing their way into private healthcare. Where did we lose the plot? Where is this gap?
See, today also people will come for second opinion to public hospital. Before doing any major surgery, they would come to public hospital, will confirm, because they will know that you will get here the best opinion and the right opinion. No doubt about that. The private I have now seen both the systems very well, actually, working in both setups. Public hospital has its own charm. Public hospital has a load, but the things are done very rightly here. If necessary, they are only done. So people would like to have a second opinion. However, there are a lot of limitations of public system, like we don't get, many times the single rooms are not available, privacy is an issue, cleanliness is an issue, overload, waiting time is very high, and sometimes courtesies and communications are at stake. Now, these are the issues which private sector really scores over. Private sectors would communicate them with well, they would give them privacy. Of course, today most of the corporate sectors will also try to have control their quality. So, but the cost, then the kind of cost you have to spend is very high. So those who can see what has happened today, if you have say 100 patients today in Mumbai, I think only about 20 will be able to, 15 or 20 will be able to afford corporate hospitals and private hospitals surgeries, I am telling you.
Surgeries. Yes.
With and only about say 20 to 25% insurance sectors which is there. So they are able to afford. Many of them will go, about another 20-25% will go to say trust hospitals with some kind of a charitable setups which we have. More than about say 40 to 50% people will still go to public hospitals, and that is where you find the kind of load we still have.
Right.
But as I said, over a period of time, public hospitals need to improve on the hospitality component. Rather than the hospital, medical component is definitely good, but what we lack probably in our hospitals is the hospitality component.
Correct.
Now, as I said, the load is very much. Now tomorrow if we decentralize and we probably get then limited patients and we have super specialty sections and those, I'm sure there will be flow of patients which will come. In fact, if you see many models in the world which are there, they run like this where they have this decentralization. But if you really compare, we are used to this quick treatment. Look at many countries where they don't get appointment for six months for even a cataract, 1.5 years for cataract in many countries which are called them as developed countries.
Correct.
And in our place, we have anything, we can walk on the same day and get it. But we have to face the
there is a flip side to
the whole
Absolutely.
thing. So the whole idea is that unless hospitals, now today what has happened because of the overall liberalization and the money is in the pocket of a common man. Whatever you say, food is not his problem now, what was there in 1960s, water is not his problem now. Many people have now homes properly. There is some amount of money in his pocket, whatever you say overall. He would now like go to a place where he will have at least this cleanliness and component and all that. That's the reason they go.
Right.
I mean, most of the places they would get a treatment, but I can assure you, all the places, even in all the sectors, he does not assure that he gets the best treatment. He may get the good hospitality, but I'm not sure whether he gets the best treatment.
So that's the matter of image. And he would take back in his mind the good hospitality, probably not understanding that he or she has not got the best treatment.
It's like, let me ask you something very simple. It's like, say, Air India versus any private airline.
Right.
When Air India was there and the private airlines came, people started asking him which airline he would choose. They said, I will choose private airline. So why do you choose private airline? Because they said they are on time, their air hostesses are young, they give good food, they are dressed well, and all these kind of questions. But then the one question which was asked was that, have you realized who is the pilot of that plane? And nobody really bothered about that pilot of the plane. So as you rightly said, what we need to have an experienced physician and the doctor and the staff is equally important. The human resource is equally important.
Right.
So you should always remember, hospitality has its own values for infection and all other things. But the human resource is also equally important. Right. So in India, at least today, we have not come to that stage where we go to a system and we forget about the person. So we still believe in the personal name of the hospital.
Right. So it's very interesting, and it's a little frustrating also from both sides.
Yes.
I think we need to lay this issue out to balance this. Municipal hospitals have a tremendous workload compared to private hospitals. The footfalls are incomparable, right? Therefore, the doctors have less time. They are overworked. They are having sleepless nights often, with emergencies coming in very frequently. They are not very well rested. And they have to go through many more patients in a day than their private hospital counterparts. It's difficult to have what we call bedside manners with any level of consistency. At the same time, the world is evolving, and now bedside manner seems to be something that is much more than being polite. It's about keeping the patient in a state of comfort and feeling safe. It's about some amount of counseling often that is given to the patient, to the relatives. Is there really time for this in a public setup? That is one question. But two, should something like this be there in a public setup at all? Or you feel?
Of course, you're absolutely right. And it's not all that. See, what has happened, two things have happened in the last 5 years. One is the number of the whole public system in these hospitals is based on residents. So it's a resident driven system. You must understand this. This is not a consultant driven system like in a private sector. It's all resident driven system. So residents are the one who are the backbone of these public hospitals. And they have energy, they have enthusiasm, they are the one who are guided by the staff which are expert and all that kind of. Number of residents have increased in the last 5-6 years. And therefore, what used to really have few years ago, like say 1980, I was one registrar and one houseman used to manage one unit in K.E.M. Today there are 12 residents.
Wow.
So there is more time to the residents to talk to patients. Patients also demand more counseling and time, even in public hospitals, and they're given. Today, nobody just tells you that you come down and I'll do a colostomy or I'll operate. You would like to have to spend a lot of time with these patients, even if he's a marginalized or poor, he would have to spend a lot of time to him before you do any surgery. And the demand is always there. There's a health awareness is good. However, as you rightly said, we need to improve the attitudes and communication of these people. So in fact, in 2018, we established a program called ATCOM. I don't know whether you are aware of. It's called as an Attitude, Ethics and Communication through National Medical Commission and the Medical Council of India. And now it is last 6-7 years, it is running fully well to improve the attitudes, ethics and communication for the doctors. How much it will have impact, I really don't know. But they have been made aware the importance of all this, and they should be able to see that even any class of patients, whether it's a high class or whether it is the absolutely new, they need this now attitude, ethics and communication, and they demand it. You can't just brush it away today.
Correct.
And I think the treatment level, and this should be same for everyone. You may be, as I said, public hospitals may be lacking some AC in OPD and rush and timing and cleanliness may be a little marginalized, but the level of treatment and this counseling and ethics should not be really compromised.
That's an amazing
and
point.
And I think most of the time I've seen these are maintained in our major hospitals in Mumbai. I must tell you that way. Yes. Very rarely I've seen this being compromised.
Fair enough. Fair enough. That's an amazing point from the inside out for Mumbaikars to listen to and appreciate what it takes to keep places like this running with a smile on your face. You mentioned the difficulty that competition with the private sector because of the kind of services that they're looking at hospitality plus. Whereas here this is fundamentally a medical delivery service, healthcare delivery service, and that is the mandate. The hospitality and the feel good becomes a mandate when you enter the private sector. It cannot be, we are not a luxury sort of setup. But is there some scope to merge the two worlds in some way, where some functions can be outsourced on campus within these large hospitals to the private sector, making it a little more seamless, a little easier?
Yes, I think we did this attempt a few times. I mean, this has been done at government level. I was in one of these PPP committees for the government of Maharashtra. We have done this in corporation many times, PPP models. Some of them have failed, some of them have worked very well. Let's look at, say, CT scans was one of the easiest to run, you know. I mean, if you see all hospitals, corporation and this government of Maharashtra cannot buy CT scans and MRIs very well. So many companies have come and they run the CT scan and MRI centers, and they do CT scan and MRI at cost of a corporation, which is 1200 rupees or 1800 rupees or 2500, which is a very reasonable cost.
Correct.
To run. They may be compromising on sometimes on films or sometimes the contrast and all, they may be charging extra, but overall the kind of delivery they give for a common man is very good.
Right.
Secondly, the kind of projects which we also did, like say Apli Chikitsa, where we tried to give those investigations from the ThyroCare and other institutions free for them.
Right.
I mean, at 50 rupees or 100 rupees, that is also very good PPP model which was there.
Right.
But some of them have not done well also, I must tell you. Seven Hills was a project which did not really do.
What was that?
Seven Hills was where they had given a plot to Seven Hill, and there was a private company which was to run, and they had to give about 20% of free treatment for municipal patients.
Right.
Plus 20% at those charity rates and all, so they could not do it.
Right.
And they went into loss. And then they have to be, municipality has taken over that project. Now it runs during COVID, and now post-COVID it is running.
Right.
So some of these PPP models, but I think there is a serious thinking government has to do, whether it's a state government or this, that the health budgets we are giving, but many, if you really see, 70% budgets go usually on the healthcare resources, I mean human resources. They go on to the salaries of people. And now sizable amount of goes into the insurance kind of payment. So infrastructural development is always weak in most of the central and the state governments. You know, I mean, we are not building hospitals. We are just giving insurances.
Right.
We are paying people. And So we need to develop these systems over a period of time. And
Right.
this is where the PPP models would work. But when you bring in PPP models, we have to also see that the private partner has to be given some degree of a leeway. You can't make it absolutely free for them.
Correct.
So either you make
Some checks and balances in place.
or you can make a parallel model, something like paying and non-paying, and then you see that there's a centralized diagnostic and there are some
Right.
beds maybe paying, some of the non-paying,
Right.
and then you try to do money from here to run the systems, and government supports that. If you develop such systems, it is okay. But now there is sometimes the integrity is an issue of people.
Right.
People try to squeeze more and they don't give this and only. So then the good monitoring has to be there if somebody wants to make this PPP model successful.
Right.
Because see, the whole concept started of PPP, I remember, was in IIM model. I don't know, in somewhere in 2000. IIM started with Chiranjeevi model. I don't know whether you have heard this model. Very interesting model. It was in Gujarat. They said 175 rupees will give you for one delivery, and for 100 deliveries will give you 17,500. That was within which you do whatever cesareans also have to be included in this. That time the cost of cesarean was around 800 rupees and delivery was say 100 rupees, 150 rupees. So the private partner is then more supposed to do less deliveries, I mean cesareans, and do more deliveries so that he gives the profit. So the healthcare also improves.
Correct.
The good model, so it worked well.
Correct.
So that was Chiranjeevi model. Then there were many models in Lucknow and all, which happened with World Bank and all. But overall, when you are doing private PPP models, we should be very clear what is the agenda of both the systems. Here, public sector wants to increase the outreach of the whole section and give more services. Private sector has to get reasonable profit, whatever their purpose is,
Right.
without squeezing people.
Correct.
And the government sector should really monitor it. So if you develop a model like this, then only PPP models work. If one sector tries to do more, or if there's an integrity issue, then these models don't work.
Right. So you need a very strong, firstly the structure with checks and balances, but equally you need a strong monitoring system which is hands-on every day. But there is a lot of benefit that can accrue to both.
Many places in the world, PPP system works.
Right.
But I think in our country, it has worked in some places, sometimes it has grossly failed.
Right. Now, one of the things is that, Mumbai, a city like Mumbai, which is the financial capital of the country, has been for so many decades together. The health of its citizens directly impacts the economy in many ways. And of course, as individuals and family members, but also as a nation. And we are fast becoming known as the diabetes capital, or we are known as the diabetes capital of the world. Non-communicable diseases, how is the BMC looking at this as in a special way?
I must tell you, Mumbai is not healthy. To be very frank, Mumbai is no way healthy. Because I think average Mumbaiker, look at life of average Mumbaiker. He spends about 2.5 hours to 3 hours in travel, coming 8 hours in his place. With rains and humidity can cause more delays.
Right.
2-3 hours in strolling into the life of others. Whatever it is, today social media works so much, 2 hours in seeing, half an hour for his family. And he has no time for exercise and his meditation.
Right.
So the food is junk, whatever we are eating, and it is bound to affect our lifestyle. So Mumbai as a city is not a healthy city, to be very frank, over years. I mean, I'm making a statement, but understanding that fortunately one good thing about is that our communicable diseases are going down, except for hepatitis B and C over years. Maybe it is because of our control of our primary health system and our EHO, and their team works well. But our diabetes has been growing very high. If you really see the number of diabetic deaths which are occurring in our city are now almost about more than, I mean, these are all recorded I'm talking about. That may be unrecorded,
So
which may be much more.
Correct.
Equal number may be there.
Correct.
Hypertension and diabetes is coming up. The number of people who are becoming early hypertensives and early diabetic is very high. And what I personally feel, it's all because of lifestyle, the kind of food. And so we need to have a healthy kind of we have to spend more time as a city on to the health of people rather than diseases of people.
Right.
And which we are not able to do as a city.
Right.
If you talk in that way. See, we have been managing hospitals.
Correct.
But how much of we are investing into the health of the people, we are not so much doing.
So it's modern lifestyles are contributing in a very big way.
Modern lifestyle, food habits.
Would you recommend reverting to more traditional diets, or would you? It's a loaded question, because we have in Mumbai, bhat bhaji pori. This is dal bhat
Poor
bhaji
man
pori.
anyway eats this.
Right.
But in spite of he has diabetes, because he also eats all junk food and no
Right.
exercise. See, there are no rooms there. Place is not there.
Right.
I mean, if you really have to go to slums and see it actually. I don't know, I mean, I was also, we were normally working in an OT and hospital. But when as a director, every Sunday I used to go and see 12 camps in slums. We used to go and see it. And we have seen Mumbai from really inside. And you must not have really seen some of the areas, how they are, especially Banganwadi and Jogeshwari, some of these areas, you go inside and all these slums, there is one small room where there are 10 people staying. Where do you really find that lady to do exercise?
Correct.
And then she's all the time in her, no light and all. So how do you really expect her to be healthy in terms of this? Then forget about mental health. I'm not talking about mental health at all.
Right.
I'm talking about physical health.
Right.
Now, that's a city we need to develop. I mean, it's a air, water. Maybe we are still giving a good quality of water. And food is, people, I mean, we have the kind of habits of people have changed.
Right.
But we have no place for exercises. We have no places for breathing. We have no places of gardens to walk like other cities.
Right.
So that's the problem of Mumbai. It's a small place where we're not able to expand.
Right. Right. This is the problem of Mumbaikars affects the marginalized majority a lot more. A paucity of public open spaces. We are under 1 square meter per capita. The standard is 10 square meters. Within this 1 square meter, we include certain cemeteries and road dividers, certain public parks which are not really public. This is something that the BMC ought to look at because it's an issue that has been silently killing a disproportionately large percentage of
It's
people.
okay to blame BMC, but I must tell you, public is also equally involved into all this.
I mean, you see, the BMC is more empowered to look at public space. Clearly, I mean, the public is to blame
It's
and
a whole
motivation.
system.
Yeah.
I don't think see, I mean, there are a lot of limitations to the BMC because of his political structure and the people, the way they behave. I feel, I mean, we have no control over anything, even in a hospital like ours.
Right.
We don't have control on whom we are just open to everyone.
Right.
I mean, let them come. I have no right to refuse a treatment for anybody.
Dr. Supe, I must tell you this, that throughout the Mumbai Manifesto series, the BMC is central to everything. Right? If it is quality of life, then BMC is the one who has to stand up in that kacheri and answer. But consistently we have found with our resources and experts who are coming in that there's a lot of appreciation for the way BMC works, the way BMC functions, and there's a lot to be grateful for, there's a lot to be thankful for as far as the Mumbaikar is concerned.
Absolutely.
So that is
to be very frank, this you may cut it, but
Yeah.
my next book I am getting published next week. It is about patient stories. I have dedicated to all the health workers of Mumbai who have been working so diligently.
That's amazing. That's absolutely amazing.
Because I feel they are the people who are the backbone and they work. I mean, they have their own limitations of their skills.
Tell us a little more about this book if you'd like to.
It's okay. I mean, it's a book which you may cut this, sorry.
Okay.
I'm coming out with a new book called Shwas Vishwas.
Shwas Vishwas.
So this book is about 60 stories which are about, there are some stories are about patients, some about the health systems and issues which are there, and some are about K.E.M.
Wow.
So what I've done, I begin with some problem and then I make people think about the health system. And there's ethics involved, there's attitude, there are resources and something like that. So this was a series which I used to publish in Sakal Avtaran. Every Saturday I used to have 1/2 page. So I've collected all of them, added few stories, and now that book is getting published next week.
Wow, congratulations and our best wishes.
So I'm trying to look at, this is the way you have to realize, when you start thinking, and see, there's two aspects of this, as a dean, I realize there's very little time to reflect. And when you I personally feel during the time you have some time, because every day morning you are busy, but once you stop and take some time to breathe, you start reflecting about the system.
Absolutely.
And then you realize what can be done and what cannot be done.
Right. It's in hindsight, I mean, but that's what, you've won now from the private sector's perspective, the public sector's perspective, as a surgeon, then as an administrator. It's a very unique view that you bring to healthcare in general, and where the two worlds of public and private can meet. I think there's a lot of opportunity and we must explore it.
Yes, we must explore it. I fully agree. There is a lot of scope, and that way, if you see, Maharashtra is that way progressive city, people are very positive, and if you are able to bring this kind of support, I think we'll be able to make some better living for Mumbaikars.
Absolutely, and we must endeavor to do that. Now, there's a very interesting question we have for you. Chinese medicine has become popular across the world. I mean, China adopted it, and today a doctor in China is able to prescribe traditional medicine or allopathic medicine. That's the kind of training they're imparted. Doctors across the US particularly have been gravitating towards Chinese medicine. Why has Ayush not seen the same success? I mean, just to caveat this question, it would almost appear that there is a little bit of hostility towards Ayush as far as the medical fraternity is concerned.
I think it's a good question. You must appreciate this. I must appreciate your thinking. See, that way I had lovely teachers who promoted homeopathy and Ayurvedic, especially Dr. Bapat, who was treasurer of YCM, and Dr. Dahanukar, who was also one of the executives of this YCM.
Right.
They used to promote Ayurvedic in a big way. So we had Ayurvedic Research Center in K.E.M. We still run, and we have a homeopathic OPD also. So my boss, Dr. Samsi, used to run a homeopathic OPD. So I personally feel there is a lot of science in this Ayurvedic and Ayurvedic, but as a public trust and public perception, we have never been able to elevate it. Even Ayurvedic doctors and homeopathic doctors want to give allopathic medicines. So we have never tried full-heartedly to treat patients with Ayurvedic. Neither public has trusted it. So if our own public doesn't trust it, on what face we are going to give it to the world? So I personally feel the research money on Ayurvedic is never utilized. So what is important, in this, China also, they started working on this and they started doing outcome-based medicine. What we need to do, lot of research on outcome-based medicine. So what do you mean by outcome-based medicine? If you look at some of the articles in JAMA, they are very interesting articles. To give you a simple example, it will make it very interesting to you. There was one Chinese weed, and they used to say that I will burn that weed at your feet and your breech will turn into a normal baby. So they took 2,000 women. This is a published paper from JAMA. This is not my own thinking. And they say half of them, they burnt a weed, half of them did not. And they showed that it works more because of whatever it is there.
Really?
Yeah, it's a published paper. So we also need to scientifically test all our Ayurvedic things and properly standardize it, commercialize it, and then send it across. What we lack is, first thing is we are doing and we try to maintain privacy, that this is our own, we don't want to share with this. And secondly, we have lack of standardization of these medicines. Now there is slightly, it has come, I'm sure last few years it has come. The medicines are available, it's not only in powder form. But about say 30 years ago, it was all powders. How do we believe a powder? You have to have some standardized medicine. Okay, ashwagandha in so many grams of this, Google, so many of this thing. And then scientifically has to be tested. So once we start showing this world, I'm sure there will be a lot of takers.
I think just to respond to you, or just to summarize my understanding of what you said, is that where China succeeded was that it was able to demonstrate that time and time again something works, and therefore it is easier to adopt.
So it's not only the concept, you bring the scientific validity, you take it to the all over the world, and then you try to see that it is practiced in alignment with the Western perceptions.
Right, right. So I think it's a failed opportunity more than anything else.
Yes.
This, I mean, we hear there's so much pride that is now being, in our traditional systems. We have always had pride, but it's being projected in a very beautiful way. I think beyond the projections, at the nuts and bolts level, we need to now get into more research, like you're saying, document that research, perhaps be able to tie up these institutions with mainstream medical institutions, because where else are they going to get a stream of patients?
No, they have been, I mean, I understand the attempts have been made, but they are so low. I mean, the Ayush Ministry has a research budget which is never utilized fully. Only 20% has been, if you look at last few years budgets, Ayush Ministry's budget for research has never been utilized fully.
That's sad, actually.
That is sad.
Yeah.
And because, I mean, and the scientific validity of these studies is always a question.
Right.
I mean, somebody would say that I treat this, but if I ask him, okay, have you documented 300 cases? What were your outcome parameters? What kind of an model which you used to prove that this was there? If you ask some 10 questions to these people, they don't stand to that scientific. And then people start.
Correct.
Actually, Dr. Dahanukar had presented, was a very classical story, I must tell you. Dr. Dahanukar worked on Google, that is Gulwel, and she developed a drug called ME&MH, which was based on Gulwel, Tinospora cardiophyllum they used to call, and they converted that tablet into one tablet called ME&MH, which was then marketed by an international company, and she presented this work into the British Parliament.
Wow.
So it's not that we don't have any examples.
Correct.
And then we used to have Ayurvedic Research Center. But as I said, that whole effort has been so limited, and we need to expand it. If you want to build our image at a national level or international level, we need to be seen as a hub of these medicines. And we need to see that, okay, there are results, there are scientific documentation, everything has to be done publicly, which we personally have not been able to. As you rightly said, this is an opportunity lost.
Correct. So, but what I'm also hearing from you is that this is an initiative much more to be pushed at the national level. It has to come that top down.
Yes. It has to come from that time. And like say, individuals have been worked on this. I'm not saying individuals have worked on Ayurvedic research, but if you see the outcome of those research has been limited.
Correct.
We need to have wider outcomes, and then those medicines have to be. And see, the biggest problem of our medicine which has been there, even Chinese medicine also, has been the lack into emergency system. See, today you have some severe appendicitis or something like that. I mean, Ayurvedic medicine has nothing to really do.
Correct.
People will still go to the allopathy and the standard medical treatment, which is absolutely fine.
Correct.
But there are some diseases, where immunological diseases, there are some diseases which are chronic diseases, some of the diseases, where at least we have a much more kind of an ability to treat these patients much better than the Western medicine, where Western medicine does not have those medicines. We should have taken advantage, where we are not able to take advantage.
Correct. So hopefully there is more momentum on this, there is more energy and political will as well at the national level. But if we want to get serious about taking Ayurveda to the world, it has to be backed by research, it has to be backed by studies, and only then can we hope to climb up this ladder of lost opportunities. Dr. Supe, while we dwell on the glory of the past in terms of Indian history and culture and medicine, the future has a little bit of an unknown component to it for the first time. We're not able to accurately predict what the next 15 years are going to be like, because technology is just growing so rapidly. Having been in charge of getting new equipment and things like this, of course there's modern technology, but now there's something like artificial intelligence, there's something like machine learning. What part of medicine is going to eventually just be given away to machines?
Oh, fine. This is my interest topic. I worked a lot on this area.
Right.
Yes, it's my topic of interest. I can speak for hours on this.
We have all the time.
But see, the first question is, AI has come a long way. Now, AI is not the word which we use. We use now deep learning and all that kind of thing. We use all this. But the first question you ask is, what is the role of AI and what it will have impact onto the healthcare? So the first thing what you should really see, AI has been helping doctors to do things better at all levels. It will not replace doctors. This is a classic statement. When Google came, everybody was worried what Google will do. But Google has never replaced a doctor. It has only helped everybody to improve the information. The same thing AI will do it. For example, in medicine, the whole data management, decision making, the AI is going to be helpful. In surgery, it is going to help me in the predicting surgical pathways, looking at it. In fact, now when you're doing a robotic surgery, it will guide me which planes to operate. It will show me all that kind of thing. In gynec, from sperm to the IVF to predicting who is likely to be, everything is going to. So the prediction is very important. So predictive analysis is going to be important. So in radiology, I'm sure it is going to be of a great help. So how do we really look at AI? You know, there are some specialities which have creativity and some specialities have repetitiveness. Some tasks are repetitive and some tasks are creative. Some require alone working, some require the communication and mental and the community working. Now those specialities where there is a community working, there is a communication, there is a counseling, these will not be much affected by AI. But some specialities where there is a repetitive processes, where you can work, like for example radiology, where the routine things will be replaced by AI, but complex things will still remain with the humans. And that we should, like say skin disease, we will have these kind of things which will be there. Then if you see mental health, neurology, they will not be helped much. Surgery, I'm sure surgical pathway I'll definitely be greatly. We have been working on AI for quite a bit in HoloLens, and we are trying to treat people across remote access. We are trying to develop 3D printing pathways, and all this will be of a great help for a surgeon. It will help me to do surgery much better and safer.
Right.
But it will not replace surgeons.
Right.
That is what you should realize. So the first thing is we should realize there are some of the tasks will be taken over by AI, some complexity will be reduced by AI, and some places where definitely a human component will be required.
Right.
So that is the role of AI which is bound to be there. And the things are becoming better and better. Of course, there are risks involved, like people are plagiarisms, people are doing fake and all that,
Right.
which is going to happen. But I personally feel AI will make life little easier for surgeons, which we used to operate in blindly. Now we will operate much more under project and pathway and all that kind of thing.
So how soon before something like these technologies makes its way into municipal health in Mumbai, for example?
See, 2016 we created first app in K.E.M for the skin. And we published saying that it can be used by any GPs, where he can use on his mobile and he can find out what is the diagnosis of the skin. So it was there. We also did one AI based data analysis where we started predicting the rain and the type of disease pattern. So it has already started coming.
Can you elaborate a little more on this?
See, nowadays we have pattern of rain in Mumbai, and the diseases really follow. It's very interesting to see in India, Mumbai. Like in Mumbai, you will find normally the rain starts in the late May or the 1st June, the 7th June.
7th June.
Then there's a heavy rain in June till August 15. Then there is Chavan comes and there is an intermittent rain, and then usually there is another small rain which is there in the September and all, and then the rain goes in November. So there is a disease pattern. Now, whenever there is a flooding, initially you start seeing lepto cases which come. Then comes malaria. Then somewhere in the month of August, July, you start seeing gastroenteritis, typhoid and more. And in the lately, when the rain becomes sparse, you start seeing dengue. Because it's very interesting. And to why it happens, because when people walk through floods, when there is a lot of water dipping, lepto comes in that first thing. After that, the malaria comes because they had the dirty water, and usually you will find gastroenteritis because of the water.
Right.
And typhoid will come because of all that which will come. Typically you will find in the month of June or July, you will find always gastroenteritis people will get. Now you'll start getting typhoids and all that kind of thing. But when the dengue breeds into clean water, and usually it breeds into the slums where there is tires or there's a small water and they put a lot of these plastics. So in that water where there is where the usually you will find the dengue grows. So dengue will grow, and if it's a lot of flowing water, it will be washed off.
Correct.
So when there is a limited amount of water and intermittent rain, then you will find dengue growing more.
Right.
So what we did, we talked with the meteorological society, and last 50-60 years of data we took of the diseases and we took of the rains, and we put that big data analysis.
Wow.
And now we have trying to develop a model which will predict the pattern of Mumbai rains, and it will tell us disease patterns. So we will know what area and how we can strengthen our public health.
Correct.
Don't you think it's very interesting?
I think it's magnificent.
One of the
yeah.
person did even thesis, PhD thesis, which is a published thesis.
Right.
It is a public domain.
Right.
So you will find this is the only limited work, but there are now many places in Mumbai have started working on 3D printing. Then all this is. We still have not entered into the field of, say, what they are doing now for avatars for diabetic control and big data management. I think we we are lacking into this.
Correct.
But corporation has huge potential for using AI to improve the predictability and services of corporation.
And it has a data repository. I don't know how much of it is digitized.
No, we still don't have HMIS.
Okay.
I think that's another thing which we need to do, which I actually started HMIS. We could establish in Nair Hospital.
Sorry, for what is HMIS?
Is the Health Management Information System.
Right.
That is where is the digital system. So we developed it completely. We installed into Nair and Kasturba, I think, one of the hospitals, Bandra Baba and other 5. And now it is being implemented in all hospitals. Because of COVID, the implementation got delayed. But once we get HMIS, I think then the kind of data we will generate will be very huge.
Correct.
And then analyze that data with base of AI, we will have tremendous predictability.
Correct.
Then we will know most of our decisions which we do. Currently, we are collecting manual data, but our decisions are based on manual data. But once you get this data, then the whole disease pattern and everything will be. So if you see, most of the recommendations of many reports have been to implement HMIS first.
Right.
So that has to be done.
And we're also getting another layer of data, although not directly, but the number of people with wearable watches which are monitoring, and the quality of wearables, what their parameters they are monitoring is also going to.
Very good.
And there will be a back end.
All of us, we have been using a lot of wearables now today. From CGM. CGM has become very common in Mumbai, especially in the corporate sector.
Correct.
Now I think CGM has become very common.
Even for type 2.
Type 2 diabetes. I have used CGM to see what is kind of a diabetes I have.
Right.
Then people have watches and health is very common. BP, pulse, I'm sure is very common. And look at the other kind of wearables people have been using.
Right.
Monitors and all. I think overall, health wearables have improved tremendously. See, what I feel is going to impact the future healthcare, there are 4 aspects you must really remember. One is the technology. The technology adoption has to be part of our life, whether AI and all that has to become. The second is there is a huge problem of pseudoscience. Pseudoscience is coming in a big way. I think because of all this technology and this AI and IT, you find a lot of, in COVID time, you see a lot of pseudoscience had come. Then fake news. People have been influenced by fake news. If you look at most of the people nowadays, the WhatsApp University, that we have to really see how authentic we try to make. And last is the communication with the patient. People are interested in communication, counseling and all. So these 4 are the future directions in which the health sector needs to work.
Right. That's amazing. I think there's so much to talk about, but we must wrap up at some point. You are somebody who's very uniquely positioned to have, like I described, the pinnacle view of private healthcare, of public healthcare from the inside, as an administrator, as a researcher, somebody with a worldview, who studied systems of medicine across the world as well. We would like a message from you for some stakeholders. The first is for politicians and administrators. The second is for young people who want to pursue medicine or have just begun to pursue medicine. And the third, as always, for us, the Mumbaikars.
Let's begin with students first. They are the simplest to really advise.
They are your love.
Love, I must tell you. What I would advise them, that students today are influenced by the technology and need. And I think they need to spend more time with patients, talk to patients, and spend more time clinically. That's my first time. You know, if you want to really today think about future, we should always think about, as I said, technology is important, but communication, counseling, talking to patients, and treat patient as a whole is very important.
Right.
That is what we are missing.
Right.
For a student, they are now on iPads, everything is available, they are on classes, they only work for NEET. So I think they should go to the wards and they should talk to patients and try to treat patient as a whole. That's my first message to them. You know, health is not something which can be learned only into classrooms. It is to be in hospitals with patients. For teachers, I would say that teachers has to balance their personal practice with the hospital commitment. Currently, we are seeing many times the practice is taking, my private practice is taking more kind of an priority over their hospital commitment, which I think public hospital should really try to see that they commit to the hospital more, at least during their period, and then they can do that. And they should always look for more academic scholarships and direction to the other word rather than just treating patients. They should be the leaders. They should not be only treaters. So that is for the students. For Mumbaikars, I would say very easily that I think we understand we work in a different, like say when I go to many other cities, I realize their lifestyle and our lifestyle, disease pattern is totally different. But every day when I sit patients and see their OPD, I feel what we need to spend time on our lifestyle. And even if you are very busy, you should spend at least 1 hour on yourself, half an hour for your exercise, whatever kind of exercises you can do, whether walk or you can do walking at home or walking around your society or do some kind of a yoga exercise, something you should do for at least half an hour. And half an hour you should spend on meditation. I think you should listen to either good classical music or a music, or you should really do meditation, because that is something which will always help you. And of course, lifestyle, other management of food, diet and exercise, which is there. And I think the dying culture of art, science and music, which I think we should try to revive. You know, we need to bring that back into our society for culture development. For politicians and administrators, it's a little difficult question. I think what happens, most of the administrators I have seen come out with their own agendas. And they would try to, BMC is a city where they has his own thing, and see what administrators and politicians really do. They should really think what Mumbai needs. Many times people have their own agendas and they do for their own agendas. I think there is enough data available and enough needs of the people. So if they listen to people rather than their colleagues, I'm talking about many times things are done because some local leader demands, or there is some kind of a political connection, or there is an influence of politicians on administrators. When it really happens, what is really needed is forgotten. So I think what I would really say to all parties, I would say, health is something which is good for everyone. It's not something for one particular party. So I think we should really see that how we can really improve the health facilities for Mumbaikars. It's not necessarily spending money. It is something, so many simple things even if you do, like more spend on healthy air, good water, walking spaces, clean flow, decentralization of the hospitals, making it accessible, I think even if you do these things, I think we'll be able to do much better for Mumbai Health. And I think that is what message I would like to give.
Dr. Supe, we know what a busy schedule you have, and we know what it has been for you to give us this time, and so much of it at that, even if it is on a Sunday. We are very grateful, we're very thankful, and we're very excited to have hosted you on the Mumbai Manifesto. Thank
Sure.
you very much.
Thank you so much. Sure.